5. Nearly, no, she's nearly 4 months.
Hi, everyone. I think we'll go ahead and get started. So I'm the chair of the search committee that brought Alison in. And Alison comes to us from Johns Hopkins. She has a master's of science in biomedical engineering and a master's in biostatistics from Hopkins, the latter, and she has a PhD in Optical from Hopkins. And we've brought her in to talk to us about her research. And she applied to a search for a social epidemiologist, and we're actually bringing her in for an interview as a exceptional other candidate. So please do not consider Allie's portfolio in the context of a social epidemiologist. We felt she had exceptional training and research in general. So I met Allie in Switzerland and just thought she was so lovely. So I'm thrilled to see her again.
Thank you. It was delightful to be here. Okay, I'm going to try to remember to turn on my microphone here. Okay, perfect. That seems to be going. Okay, so thank you very much for the invitation. I'm happy to be here, and I will be speaking about better aging. I'm going to talk a little bit about the challenges that I see in achieving that, and some of the opportunities I see for making aging better for hopefully everyone. All right, so we all want to look like, oh, I can't work this. Hold on. This woman right here. That's what we're all trying to be. Okay.
There's nothing wrong with the guy either.
What's that? Yeah. He's very creative in how he looks at his cell phone. Okay, so why should we be talking about aging? Let's talk first about kind of the problem, the big issue. So I have a colleague who has a funded study to look at aging, and she called the study the Silver Tsunami. And I thought this was just a fabulous name because it really calls to mind the idea of this wave of beautiful silver-haired people coming our way, and to some extent already here. And in fact, by the time we hit 2030, that's when the last baby boomer is going to turn 65. 1 out of 5 Americans will be an older adult, which is pretty staggering. So 72 million people. And along with this aging cohort, we have the effects of aging. So to a great extent right now, that's chronic comorbidity. Things like cancer, cardiovascular disease, stroke, Alzheimer's disease, heart disease. All of these things are going to be growing with our growing population. And so that's a burden both on the individual and also on the healthcare system, particularly when we think about the fact that these things don't tend to come in singles. They often come in pairs in older adults, and quadruplets and triplets. And that's a lot for an individual, an older adult, to manage. They have to manage multiple medications. They have to manage multiple doctor's appointments. And it's a burden on the healthcare system because the healthcare system has to coordinate that care across many disciplines. And the ripples really start to go beyond that because the individuals who are also affected aren't just the older adults, aren't just the healthcare system, but the families and the loved ones. So 25% of adults, and I thought this was really surprising, report that they care for somebody currently who has a chronic illness or a disability. And in the general population, having to care for somebody is related to your own stress and your own likelihood of developing an illness. So not only do we have this large number of people who are potentially going to have complicated care, but we're also going to have a ripple effect of other people who are assisting those people, who are caring for those people, who will also need care. So this is a lot to place on our healthcare system, and that's why it's important to be thinking about this. Okay, the good news is this is not a problem that's any way under the radar. So if you look at Healthy People 2020, you're going to see a whole section on aging and older adults. If you look at the CDC, they have the report on health and aging. If you look at the funding levels for various institutes that fund research for looking at chronic comorbidity, you see that those levels are rising, particularly NIA with an Alzheimer's push. So we are well aware that this is coming, and we're trying to prep for it. And it's not just us in the US. All of the developed countries are seeing the same thing, aging populations. In fact, Japan is now the oldest country. Now, what I'm showing here is from the Federal Office of Public Health out of Switzerland. And so they are also well aware of this problem and are looking at the same thing. This is their national strategy for prevention of non-communicable diseases. And I pulled this in particular because I really liked the way that they wrote it, which is surprising because it's written in English, which is not one of their 4 national languages. But despite that, they really had some nice takes on things. So the report starts with a discussion of primary prevention. The idea that a healthy lifestyle would help prevent many of the conditions and reduce their consequences, right? So primary prevention is kind of, we think of it in EPI, I think is the holy grail. We're all very interested in primary prevention, and it's where we spend a lot of our time. A lot of our research now is risk factor research, trying to find modifiable factors that can allow us to prevent the disease, right? And prevention seems like the best strategy of all. However, what is nice here is that they went beyond this. And I think that's going to be key for us. We have to go beyond primary prevention. And I'm going to talk a little bit about why I think that. So what you see in the vision statement from this report, right up front, the first statement here is tertiary prevention. More people stay healthy or enjoy a high quality of life despite their chronic illness. And when you talk to an aging person, this is actually their holy grail, right? Whether you have a chronic disease or not, we want you to maintain functioning, right? If you maintain functioning, you maintain your quality of life, and that's really the most important thing. So I think this is a really key aspect for us to be thinking about as we move forward into this wave. The other thing that I like in this statement is right here, this health equity statement. The idea of regardless of socioeconomic status, everybody should have equal opportunity for good health, right? Something we all believe in. And I think this is another important point for us to think about as we face the stressors that are coming to our healthcare system and society and individuals. Okay, so I don't want to poo-poo primary prevention in any way. It's incredibly important, but I think there are big challenges and it won't solve our problem. And this is why. While it's theoretically doable to do primary prevention for a lot of the comorbidity that we see in our older adults, the problem is a lot of these things we've known. We know all of the things, a lot of the things that can make a huge impact in our risk for chronic disease, right? We know that you shouldn't smoke. We know you need to get exercise. We know that maintaining a healthy body habitus is important. We know you shouldn't drink excessively. We know you shouldn't be too stressed. All of these things we've known for decades, right? So we've been doing primary prevention around these topics for a long time. However, when you look at the data, and I'm showing data here from the Behavioral Risk Factor Surveillance System, this is through CDC, you can pull data on behavior, people's reported behavior. And what you find, and I pulled the data specifically for 45 to 55-year-olds, these are our middle-aged cohort. They're looking around the corner towards their older adult years, but there's time for them to modify their behavior. This should be kind of when you're most motivated, maybe, to modify your behavior. You're starting to see your older years creep up on you. But when we look at the behaviors, and I compared 2012, 2013 to 2016, 2017, when you go down all these things, and I did the math right here, and these reddish numbers, they're supposed to be red, are things that are moving in kind of a direction we wouldn't like them to move. And the green ones are the ones that are moving in a direction we're pretty happy about. So there are two things, vegetable consumption and smoking, that we can feel pretty good about. the other things we feel less good about. But before we pat ourselves on the back, we should remember that we've been working on anti-smoking since at least 1964, when the landmark Surgeon General's report came out. We've been doing this for a long time. And the fact that we're looking in 45 to 55-year-olds and still seeing 20% reporting that they currently smoke is, I don't know, a little bit upsetting, a little bit demoralizing. And what it suggests to me is that there is probably this core group that's going to be there that will just be tough nuts to crack in terms of primary prevention. You know, a group that's just not going to give up their bad behaviors very easily. And so I think as we put more and more effort into doing the same kind of population-based primary prevention, we're going to see diminishing returns for that investment, right? So this suggests that we have to start becoming a little smarter about how we do primary prevention, and we have to kind of broaden out about how we think about prevention. So I wanted to just share one example from some of the work I've done that really highlighted how difficult it is to change behavior and how much we need to get very clever. So we did this study. I work in a cohort of children with chronic kidney disease. So this is primary disease, and it's rare, thankfully, but when a child has chronic kidney disease, it's a huge impact on their lives. They have hypertension. These are, young kids. They have growth failure. They don't develop neurocognitively as normally as we would hope they would. They have problems with their bones because their serum chemistry is out of whack. So these kids have a lot of issues that make, their quality of life lower than it should be for a kid. And there's not a lot that can be done because this is a progressive disease, and what gets done at the final end of the day is a kidney transplant, which sometimes works and sometimes doesn't, and kidneys are hard to come by. So what doctors really focus on, what nephrologists focus on, is trying to slow progression. They want these kids to stay healthy as long as they can. And one way to do that is to reduce all those sequelae of the disease. So if we can eliminate their hypertension through good treatment, if we can restore their serum chemistry balances to normal, then we'll slow progression. That's what the data seems to indicate. So one way to do that, of course, is through medications. There's some good medications that treat hypertension, for example. But another way to do that, another emphasis is on the diet, right? So we can bring down sodium levels. We can alter the diet to try to address serum chemistry imbalances. And so these kids get a lot of dietary advice. Their doctor talks to them about their diet. They go see dietitians all the time. So that's the setup. So what we wanted to do was look, because we had food frequency questionnaire data, at how these children were doing in terms of their diet. We wanted to look at the nutrient content of their diet and see how all of this information they were receiving, all this intervention, affected what they were doing in terms of their healthy diet behaviors. And at the end of the day, the summary is that we found they were eating every bit as much high sodium, high calorie, low nutrition food as any average kid in the population. There was no difference, right? Despite all of this intervention. And we worked with these two lovely dietitians, Christy and Laura. And when I showed the data to Christy, she said, well, I'm not surprised. Do you know how many come to Jesus talks I've had with these kids and families? So she knew that this was what we were going to see. All of her efforts, she knew that it's just really hard to change behaviors. Okay, so I don't want to be depressing about this because I think that there's a lot that we can do, and in the realm of primary prevention. So one thing to think about is whether there are certain groups that we can have a bigger impact in. So the minority population is growing. The older adult minority population is growing. they're estimated to be about 40% of the overall older adult population by the year 2050. So that is a big chunk of our older adult population. So we have a lot of people that we could affect, right? And then what we know is that there is a social gradient to health, right? And in the US, race tends to be linked fairly tightly to a lot of socioeconomic indicators. So that means what we tend to see is that minority populations, minority groups have worse health indicators. You see that Blacks tend to have higher levels of hypertension, Mexican Americans tend to have poorer control. So we see a lot of these indicators in these health marginalized populations. And we know it costs us a lot of money. $6.7 billion, it's estimated to cost us in extra health care because of these disparities. So what does this mean for us? Well, health equity is something we all think we should be doing. It's the right thing to do, but more than that, it presents an opportunity, right? These are people that we're just not reaching well. So how can we target them better? We can do a lot in this population. It's the right thing to do, and it's where we may be able to make the biggest impact. And, you know, primary prevention is about finding ways to make the healthy choice the easy choice. But that becomes a very personalized calculus, right? When does it become easy for me to eat better? And so figuring out how to target these groups, these populations, work within their cultures or their barriers, that's where we can go to make a big difference. And in the end, of course, you know, that's what we want to do. Okay, so there's another population that's actually been identified in the Aging and Health Report, and that is the LGBT community. This is also a growing population. They make up about 2 million of our older adults currently, and that's estimated to double by 2030. So it's a growing cohort of individuals. And what we know about LGBT is just like a lot of our other minority groups, they don't get integrated into our healthcare system as well as they could. Just like Blacks and Latinos tend to have lower rates of insurance and access into healthcare, we see a lot of these similar issues among LGBT being denied healthcare. So there's a healthcare access issue, but also they have high risk for a lot of comorbidities and behaviors. They're more likely to be depressed. They're more likely to be disabled. They're more likely to drink excessively. They're more likely to smoke compared to their heterosexual counterparts. So a lot that we can work with here in order to impact what we see in terms of the outcomes in our community. These are individuals who are also more socially vulnerable. So gay and bisexual older adult men tend to live alone. And living alone is associated in the general population with depression, with cognitive impairment, with physical impairment, with early comorbidity, and early death. So here's another great opportunity for doing some good work in primary prevention if we can get smarter about our strategies and our targeting. Okay, so I'm going to switch gears and talk about another area where I see a lot of opportunity, and that is sensory deficit. Now, this is an area that's a little bit under the radar. Despite being a highly prevalent problem in older adults, we just don't tend to detect it very well. And I think part of this is because it sneaks up on people. They don't really realize the extent to which they've lost their hearing or their vision because it's occurred very slowly. But also, it tends to be something we think is just normal in aging. You know, I don't hear well, but yeah, I hear pretty good for my age. I don't see well, but you know, I'm 80. What do you expect? So people don't really think about it as a problem that can potentially be corrected. But your vision and your hearing have a huge impact on how well you navigate your environment and your social situations. And here's an example to bring home the point. Just imagine if what you saw when you went out in the world were these pictures. I've just lowered the contrast, right, to simulate somebody with contrast sensitivity deficit, compared to these nice clear pictures here. You know, how would that impact your life? How would that impact your job and how you get around? It would probably have a very big impact on those aspects of your life. So thinking about how we can target these issues and remembering that they're something that we can correct in a lot of people is an important thing to consider. And just to note, your sensory ability is linked to a lot of other outcomes in older adults. Older adults tend to give up driving because they feel like they can't see well, right? And they get depressed because they can't get around because they can't see well, right? They're not engaging in their activities. So we can correct a lot of these problems in some parts of the older adult population by simply giving them good corrective lenses or a hearing aid. So sensory loss plays a big role in a lot of the domains of healthy aging. It impacts your ability to keep socially engaged and active, your ability to maintain your cognitive vitality, your ability to avoid injury, to maintain your physical mobility and activity. I haven't seen any data about health economics, but it may be in there as well. And let's just take some time to kind of dig into a couple of these areas so I can really show you the links. So first, let's talk a little bit about sensory loss and avoiding injury and maintaining your physical function. So maintaining physical function is one of those very important domains that we think about for people who are aging. The ability to continue to engage in their activities. And you can imagine that even in the context of a disability, if the adult is able to continue to do what they've always done, right, all the things they love doing, then they will perceive their life as having high quality, right, regardless of whether they have a disease. But what we see when we look at the data is that there's a high prevalence of disability in our older adult population. Around 50% report some level of disability. So that's a lot of people who aren't able to engage in their normal activities. That includes 30% who report not being able to climb stairs. 19% report that they have trouble with instrumental activities of daily living. These are the things that are your organizational tasks, like, you know, balancing your checkbook. And then 13% report that they have trouble with activities of daily living. These are just the basic care function. You know, can I feed myself? Can I clothe myself? So this is a lot of an impact on individuals' lives. And it makes sense, of course, that sensory deficit might play a role in some of these things. And to look at that closely, what we did was we put a survey into a population of aging adult men who have sex with men, both HIV infected and HIV uninfected. The HIV infected older adult community is a high risk population for a lot of chronic comorbidity. So it's an interesting population to look in for a lot of our aging diseases. So we wanted to see whether or not there was a high prevalence of reported vision issues and how that related to their physical functioning and their other comorbidities. So this survey asked them, you know, due to your vision, do you have trouble doing various tasks? And the tasks included reading print, cooking and sewing, things around the house, going upstairs, noticing objects off to the side while you walk, finding something on a crowded shelf, and driving in the daytime. And so when we looked at the data, and we categorized this by no difficulty, a little difficulty, moderate difficulty, and extreme difficulty, or they can't do because of their vision. So those are the bars right there that you can see. And then we layered on top of that indicators of their physical functioning. So we have slow gait speed, we have impaired instrumental activities of daily living, and we have whether or not they met the definition of frailty. And you'll notice that as the degree of impairment on one or more of those tasks went up, so went all of these indicators of impaired physical functioning. And that certainly shouldn't be a surprise to us. If I can't see well, I'm probably not walking very fast around. If I can't print well, I'm probably not balancing my checkbook. So it's not surprising that there are links here. But what we think is that vision impairment may also hasten physical decline. And I'm going to show you a little bit of why we think that's so. Okay, so there's a very deep literature in falls prevention. A lot of people have run clinical trials trying to prevent falls in older adults. And there were recently 2 reviews that came out, one in JAMA and one by the U.S. Preventive Services Task Force. And what I'm showing here was a nice editorial written by Eric Larson in JAMA about the JAMA review. And what he notes is that the best intervention is really, keeping people physically fit. So exercise, physical activity, this will help prevent falls. However, and I've highlighted what he said in yellow there, vision assessment, when you add that on to an intervention of physical activity, you see even more reduction in falls. And he noted that, this is something that primary care physicians can promote. This is something we can easily talk about in public health messaging. And visual impairment's highly prevalent. It has this insidious onset, so people don't go in about it. But it can be corrected in a lot of cases, right? So we can correct this problem of falls to some extent by getting people in to see their vision care specialist and making sure that they exercise. Okay, so why are falls important? It's not falls alone, but the fact that falls can lead to fractures. And fractures can be really devastating for an older adult. So this is a article that was written by Luigi Ferrucci and Jack Girelnik, and Luigi Ferrucci is actually the PI of the Baltimore Longitudinal Study of Aging. So he's been looking at aging a lot. And what they talked about in this article was that a loss of mobility occurs when our compensatory mechanisms fail. And this failure is then a turning point for an older person's life course. He calls it a catastrophic juncture with consequences in all aspects of their life. So that turning point, that thing that causes our compensatory mechanism to fail, is often a fracture for an older adult. That's the point at which they get bedridden for a while, they lose muscle mass, they lose physical fitness, and it's this cycle that just precipitates a steady, fast decline towards frailty and death. And if vision function is playing a role in this, then vision function can be contributing to that catastrophic event that leads people to lose their quality of life. Okay, so let's switch gears and talk a little bit about cognitive vitality, another really important domain for healthy aging. So what does sensory deficit have to do with cognitive function? Well, there's, again, a wealth of literature that's coming out. It's building literature. It's not quite like the Falls literature. But we're seeing in the data more and more that there are these links between hearing impairment and vision impairment and cognition, cognitive decline. So not just cognition, but cognitive decline. So why might that be? Well, there's a number of potential mechanisms. So first, you can imagine if you have a degraded signal coming into your brain, right? You can't really hear me very well. You can't see me very well. You have to expend extra cognitive load in order to interpret that signal, right? It's like an encrypted message coming into your brain, and you have to work a lot harder. And that means you have less cognitive reserve left over for doing things like remembering where your car keys are, or having the impulse control not to eat, you know, the whole pantry full of chocolate. I'm still looking for that impulse control. So that's one idea. The other idea is this kind of use it or you lose it idea. So if the brain perceives that it's not getting good information from your hearing and your vision, you may actually have cells recruited away, neurons recruited to do other tasks, right? So then we're going to lose cognitive ability in terms of vision processing and hearing processing. And then the last idea, and this is a place where I spend a lot of my time with several colleagues, is the idea that there's a shared pathology. So there's some systemic process that's going on, pathological process, and that's affecting the brain and it's affecting the senses. And so the senses may be just giving us hints as to what's going on in the brain. So why is it important to think about these links? Well, cognitive function is as important as physical function for maintaining high quality life in your older years. And in fact, if you ask older adults, you know, what's the thing you worry about most as you age? What they're going to tell you is they worry about losing their cognitive ability. That's going to be the thing that scares them most. And we know that this is a growing burden. So this is data just for Alzheimer's disease, which makes up about 50 to 60% of all of dementia. So just, you know, one portion of it, although the bigger chunk. So by the year 2060, it's estimated that we're going to have 14 million Alzheimer's disease cases. It costs us around $236 billion a year. And as you saw before, it's the 6th leading cause of death. So that's a large burden of comorbidity. And again, this is just one portion of the overall dementia picture. So there's a couple things to note with dementia. And that is, first, that the onset of this disease is, we think, very long, 20 years. There's a pathologic process going on in your brain causing damage. And it's only 20 years down the road that you finally exhibit clinical symptoms. But by the time you exhibit those clinical symptoms, it's really late in the game. You've had a lot of damage that's occurred in your brain. And being able to regain some control, to intervene in some ways, is really difficult at that point. So what this means is we would like to try to find a way to detect this pathology early, sometime early in that 20-year window, and intervene in some ways. And I have to be completely honest, there aren't a lot of really good interventions. But when we do get great interventions, we need to be able to detect the disease process in order to have those be usable. So it's easy to think that we can just look in the brain to do that. We have MRIs. They should show us this stuff. And they do show us some of the pathology. They show us cortical atrophy. They show us small vessel disease that's contributing. But by the time you see those on an MRI, it's, again, pretty late in the game. That's a long way towards being either clinically symptomatic or just before you're clinically symptomatic. So that's not really the tool that we're going to be able to use. In fact, autopsy studies indicate that one of the pathological elements that seems to be really important are these little microinfarcts that occur. So microvascular disease. Things are way too small to really be picked up on MRIs. So the thing that's interesting about a link between your cognitive function and your senses is that potentially we might be able to use your senses, sensory deficit or pathology in your senses, in order to be an early warning system for the pathologic process that's going on and leading to dementia. That's the idea. And the eye has some distinct advantages as an early warning system. So for those who remember their high school physiology, the eye and the retina is actually an offshoot of the early brain, right? Or as ophthalmologists would say, the brain is an offshoot of the eye. So they share a lot of elements. They are both highly metabolically active tissues. They have similar patterns of vascularization, and they have similar vascular regulatory processes. So there's a lot of reasons to think that what we see in the retina is what's going on in the brain. And what's really cool about the eye is you can see the back of the eye with the naked eye. When you go to your eye care specialist, what do? They shine this really bright light into your eye and they look at your retina, right? Or we can use cameras to do this. So you can see the pathology ongoing without having to do too much. So we tried to leverage this idea, and we started a study called the Eye Determinants and Cognition Study, or IDOC. And we don't use the naked eye to look at the retina, but we use a device called Optical Coherence Tomography. And this is a really cool device that shines a light into the back of the eye, and then it looks at the frequency domain of the returning light. And from that, it can get these amazing pictures of the structure and the vasculature. So let me try to take you through some of the pictures here so you can see what's going on. So here you can see the OCT machine right there. And this is Melissa. She's at our Hagerstown site, Maryland. We're also in Jackson, Mississippi. And over here is Tammy. She's another one of our staff. And so you can see that there's this is non-invasive, right? So she just leans her head up against the machine, and then she has to focus, and then the images are taken. And when we get the images, one thing we get to see right here is this cross section of the tissue in the back of the eye going down into the retina. So the light would be coming from Melissa down. Here's the fovea. This is the area of your best vision. This is the highest concentration of cones. And then right over here is, you see where it says nerve fiber layer. The axons for all of the rods and cones, all the cells down here that help us with our vision, they're all running along the surface of the retina right there. And so what we can do is we can measure the thickness of that nerve fiber layer, and it tells us information about the health and the number of the cells underneath, right? So as we lose cells in our eye, lose those neurons due to pathology, that layer is going to thin. Those axons are going to shrivel up and go away. So if this sounds sort of like the process that we think of that goes on with Alzheimer's, where you have this atrophy of the cortical tissue, that's exactly the idea. We're hoping that this is exactly echoing what's going on in the brain. Now over here, what you see are the OCT angiography images. So these are the images that are tailored to looking at the microvasculature. And up above here, this is a normal eye. And in the normal eye, there's one area right here in the center. It's called the foveal avascular zone. That's the only place in the retina that shouldn't have perfusion. But if you look at a patient with diabetic retinopathy, what you see are all of these areas that have no perfusion, right? And what these things seem to be very similar to are microinfarcts that occur in the brain. So once again, the hope is that we see similar processes occurring in the eye as are going on in the brain due to some pathologic process that's leading a person down the road to cognitive impairment. Now, I don't want to give short shrift to hearing, because hearing is also incredibly important. And in fact, if you look at a recent Lancet review about dementia prevention, it's hearing loss that comes up as the biggest modifiable contributor to dementia risk, 9%. And I know that doesn't sound like a lot, but it's more than any of these other single identified risk factors for dementia. And so hearing loss, particularly in midlife, is incredibly important to focus on, not just for function, but also potentially for preventing dementia. And that's really important to know when you realize that 80% of individuals who could benefit from a hearing aid don't wear one. So that's a huge segment of the population with hearing loss that could be corrected that we're not effectively correcting. Now, vision function, we don't think probably directly contributes to your dementia risk, but it does contribute through many of these other factors. We know it contributes to depression. We know it contributes to physical inactivity, and we know it contributes to social isolation. So that's another 9% right there. Okay, so I'm going to switch gears again to talk about just one last place where I see a lot of opportunity for us in terms of prevention. And this is the idea of bringing older adults in to be partners in their care, bringing them into the process of helping them navigate and treat their ailments. And so, again, I'm drawing from Switzerland, their Federal Council's Health Policy Priorities. This is their Health 2020, and that sounds to me a lot like Healthy People 2020. So I was wondering who stole the name from whom. I'm sure that the Swiss won't tell me. But they have an objective in this that's to empower insurees and patients to increase their health skills, their individual responsibility, to make them more efficient and effective at managing their care. And, you know, underlying the way they kind of state this is a lot of ideas of collaboration and dignity and respect, all these really good ideas around patient-centered care. But from a public health perspective, what's also really important to note is that patient participation in medical care seems to lead to improved health outcomes and more satisfaction with the care. Now, what do you need in order for older adults to become participants in their care? You need good information flow, right? Information and knowledge has to flow freely from the doctor, from the healthcare facility to the patient in a way that they can internalize it and act on it. And that's the place where the CDC has really focused, is this idea of health literacy. They talk about in Healthy People 2020, the fact that we could be communicating more effectively with our older adults. So really focusing on this communication piece. And they define health literacy as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Okay, so how are we doing with this? Well, if we look at the National Assessment of Adult Literacy, we're maybe not doing so great. For adults greater than 60 years, we see that a significant portion of them have difficulty using printed materials. They have difficulty with the documents and the forms and the charts that we're giving them. They have difficulty interpreting the numbers. So we're not doing a great job of communicating with our older adults in a way that they can internalize, they can understand, and then use to engage with their healthcare provider to manage their own care. And I think that there's a lot of room here for us to get a little bit smarter then about how we communicate, figure out new strategies and better tools for doing that. And I want to just take through one example from some of the work that I've done. So I don't want to represent this by any means as the key to everything, but we did find that it was the key to a couple things for a particular population. And this is a population of patients with autosomal dominant polycystic kidney disease. So these patients have progressive disease. They get a lot of tests. They have to make a lot of healthcare decisions. But what motivated us to design a shared decision-making tool in the form of this clinical report was the fact that a new treatment had just come out called tolvaptan. And this treatment was the first treatment ever to show that it could slow progression in ADPKD patients. However, it had some really serious side effects that really impacted their quality of life. So you can imagine that nephrologists who are caring for these patients thought, you know, this is really a decision that has to be a very personal one about whether or not this treatment is right for the individual given their life circumstances and their tolerance for risk. So we designed this report, and what we tried to do was take the indicators that the clinician themselves use to evaluate the progression of the patient. And we used very simple language. I know it's hard to see because it's in German, but it's very simple language if you're a German speaker, to explain what those indicators are, and then show graphically what was happening relative to other people in the cohort. So other individuals with ADPKD, how well are you doing? And this tool was meant to be used, with the doctor there. So in conjunction with a visit to the nephrologist, the patient would sit down with this report and they would go through what it all meant, and then they would talk about the options. So we did some qualitative work before part of the development, and then afterwards to see how well it was received by the patient group. And what we heard from them was that they did feel better able to make decisions about their treatment. They did feel better able to understand their progression, the severity of their disease. This did not make them feel like they were better able to handle their symptoms or make better health choices to manage their care or handle emergencies. So I think there's not going to be one tool that's going to fit all situations, but I think we can definitely get very smart about developing some communication strategies that target certain barriers to communicating with patients and to having them engage in their care. Okay, so I'm going to wrap up with some healthy aging takeaways, some of the things that I hope I've conveyed. So first, I think it's not about halting aging, right? We're never going to get rid of all of the accumulation of the small and large effects of aging. But it's about maintaining high quality life, right? Can we maintain functioning in individuals regardless of their comorbidity? You can see right here, this gentleman, he's monitoring his blood pressure. He may be on medication, but he looks very, very happy. And that's a good definition of successful aging. Secondly, primary prevention is great. We all do a lot of it. And obviously, if we can halt the disease before it starts, that's ideal. But it may get us only so far without being a little bit more clever about our targeting approaches, finding the places where we can really make an impact, or about getting a little bit better with how we communicate using kind of modern communication tools to do a better job. Sensory deficit. So I think this is a big opportunity for primary, secondary, and tertiary prevention. It goes across all bounds, and it's under the radar, and a lot of these are correctable. So, how can we not be focusing here? And finally, I think bringing older adults in to be partners in achieving healthier, better aging is critical, not only because it's about respect and dignity, but because it can really have a big impact on how well they uptake their care, how well they take their medications and show up for their visits, and that's obviously important. Okay, so I'm going to just take a couple seconds to just give some acknowledgements. I talked about the iDeterminants of Cognition study. So that's a picture of some of our team. We have a very big team because we have 2 sites, and we have the Hopkins main site, and then we have an OCT reading center and a DCC. So we have a lot of people involved. I showed some data from the multi-center AIDS cohort study, and some data from the Center on Aging and Health and the Cochlear Center for Hearing and Public Health, and then some data from the University of Zurich and the Hirslanden Clinic, and then from the Chronic Kidney Disease in Children study. So I want to thank all of those entities for building the research that I based this talk on. And I want to thank all of you for being here. I would love to have a further discussion if we have time, which I think we do. Thank you very much. Yes, please.
Hi, very nice talk. I have a question about the OCT.
Yeah.
Is it an established biomarker for brain decline? We're doing OCTs in the diabetes prevention program.
Yes, diabetic retinopathy.
Well, not only that, but aging-related outcomes. And we're also doing neurocognitive tests. we're not doing brain MRIs.
Yeah.
Is this an established relationship, or should we establish because we have some data?
Yeah, so it is not established in the sense that it's not an accepted fact that these things are related. By related, I mean that I can go in your eye and I will see later pathology. You know, I'm seeing your risk in the future. Absolutely. Do we see these markers at a higher prevalence in Alzheimer's patients compared to non-Alzheimer's? Yeah, but that's to some extent uninteresting because they already have a diagnosis of Alzheimer's, so that's not helping. There's a lot of tantalizing, tidbits in the literature, but I think we're not there yet with being able to definitively say that this is actually going to make a difference for prevention. I mean, the ultimate goal, if you can picture into the future, would be, a screening strategy where older adults come into a community center or a vision care center and they sit down, they get their OCT, it reads out a risk and maybe an etiology statement, and then they also go get their vision corrected, and we're dealing with a lot of aspects, of poor outcomes. But that is way far in the future.
We should study it, right?
So we should study it. Exactly. Right. Oh, yeah.
Another question.
Yeah, please.
So you appropriately criticize primary prevention, not too harsh.
Okay, right.
You didn't mention anything about primordial prevention.
Oh.
Which comes even
further
in life.
Yes.
And it might be one of the answers to the questions you were raising.
Right, absolutely. That's a great. I don't mention it because it is out of my realm of expertise by several degrees. But I absolutely, I think of this as all hands on deck. Any place where we can put effort that will chip away at the problem. Why aren't we doing that?
Probably starting to even prevent those behaviors that once established we can't change.
Yeah, absolutely. Get them while they're young. Yeah, I think that's a great point. Yeah.
What type of funding source would like to incentivize the sensory deficit you mentioned, like through screening in optical centers in Costco, Walmart?
Yeah, right.
Funding source would like to.
You mean we have to fund this? That sounds crazy.
Yeah.
I can tell you the study is funded by the National Institute of Aging. And I had a discussion earlier with Carolyn about NEI. The National Eye Institute actually doesn't fund this kind of research.
Doesn't?
No, they don't. This is not really where they tend to be because the outcome is really in the brain. So they don't necessarily see it as their purview. Right. Please write letters. Please call.
AHRQ. How about AHRQ?
Yeah, right. And then, of course, there's lots of foundations that deal with Alzheimer's and other dementias. So those are also good places to think about for funding. Yep. Yeah.
With the research that you were talking about with the children who had chronic kidney disease, but they were not adhering to a low-sodium diet, you said that the nutritionists on the study were not super surprised to see that.
Yeah. That's a hard job.
Right. Did you guys find anything that was connected to this non-adherence in terms of social context, or just did the participants give you anything to indicate why they were non-compliant other than they just prefer the salty, sugary, diabetes-inducing food?
Yeah, it's a really good question. I mean, the basic answer is no. We don't know. I can tell you that these children tend to come out of families that are often have a lot of lower SES indicators. So that could hint that there's a lot of things going on in their lives, and maybe not having salty snacks is like the lowest thing on their priority list. But I can also tell you that these parents are very engaged. I mean, they're in a study, right? They're in a study that takes a lot of time, and they are looking at all the literature we're sending them. They are educating themselves on their kids' disease. So I would have said that they were engaged families. So, I don't know. It's sort of surprising.
Yeah, I mean, well, I'm a sociologist by training.
So you can answer this question.
Probably not, but I mean, the things that I would think of like social context. So, like, are they in food deserts? Do they have financial barriers to eating healthy?
Yeah.
If people are receiving SNAP benefits or WIC, the kinds of foods that are subsidized and qualified aren't always going to be healthy.
Yep.
Also, in multicultural populations, sometimes people prefer to adhere to a diet that's more consistent with their native population. Sometimes those things do or do not adhere or align with low sodium diet. So I was just wondering if any of those things were borne out in what you saw.
Yeah, it's not the latter. So the kind of things that were forming their food choices were potato chips, French fries, McDonald's kind of stuff. So it's the real American junky food.
Okay.
It wasn't like a cultural specific diet. Okay. Yeah. But the other things are absolutely a potential. Yeah.
Thank you. I think we have a class coming in.
Okay,
Thank you, Allie.
Thank you so much.